Okay, it's just after 12, so I'm going to go ahead and get started. Welcome, everybody, and thanks again for joining us this afternoon. My name is Melissa DeMars, and I'm the Northern Michigan Behavioral Health Consultant for the Michigan Opioid Collaborative. And this is our webinar on alcohol use disorders, epidemiology, and clinical best practice, presented by Dr. Ann Fernandez, whom I'll introduce shortly. Before we get started, a couple things to go over. On the screen, we do have the CME information. If you're trying to obtain CME credits for today, feel free to follow the instructions or use the QR code. For social work and McBath credits, we will be posting a PDF with links and instructions for obtaining those credits in the chat throughout the webinar. The continuing education credits do expire by 12 p.m. on Saturday, October 28th, so please make sure you complete the process before that time. Please make sure you remain muted if you are not sharing. If you have questions, please use the Q&A function instead of the chat. We have a lot of people attending today, so this makes it easier for us to monitor the questions. If you look towards the bottom of your screen, the Q&A icon is between the participant and chat icons. Please click on Q&A and post your questions there. We'll be monitoring the Q&A section and we'll do our best to make sure all questions get answered. Finally, if you haven't already, please sign into the chat with your name, email address, and organization. If you didn't register and are attending, or if your Zoom screen name is not your full name, this is the only way we can verify you as an attendee and get you the resources from today. Thank you, we appreciate it. So I'm going to share a brief overview of the Michigan Opioid Collaborative. We are an interdisciplinary team supporting providers and communities to increase office-based addiction treatment and expand care and improve quality of care with patients with opioid use and other substance use disorders throughout Michigan. The MOC is grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer free same-day consultation services to help provide evidence-based quality addiction treatment. Our team of physician specialists are available to help with patient case questions related to treatment and management of substance use disorders Monday through Friday, 9 to 5 p.m. Eastern Standard Time. The MOC offers quarterly introduction to buprenorphine trainings as well as webinars on a variety of educational topics such as addiction, stigma, and substance use. Many of our trainings and webinars offer free CMEs, CEUs, and McBath credits. All of the MOC educational events offering CMEs do meet the new DEA 8-hour substance use disorder education requirement. We have created toolkits for providers to have more resources when treating patients with multiple substance use disorders. All of our resources and toolkits are available through our website. Okay, with that, I'm going to stop sharing my screen and introduce our presenter. Dr. Fernandez is a clinical psychologist whose research focuses on interventions for alcohol use disorders, including brief motivational interventions in healthcare settings. Her work focuses on developing screening and intervention approaches to reduce risky alcohol use among elective surgical patients. She is also interested in the broader area of health psychology and medical decision-making, and has conducted research on vaccination, cancer prevention, and health-related quality of life. We want to thank you, Anne, for being with us today, and I'm going to hand it over to you.
Thanks so much. So I have slides I'm going to present today. I'm really happy to be here and excited to talk about this topic. It's very near and dear to my heart, as well as my own clinical work that I do. I just see patients at University of Michigan in our outpatient clinic, as well as an alcohol-related liver disease clinic here, as well as do research. A lot of my research focuses on alcohol use. So I just wanted to say before I jump in, I put slides together on this topic, and I always try to really imagine my audience when I'm thinking about slides, but it's hard to know exactly, the range of expertise and interest. So I really encourage you, as I'm going through, if you have questions, to ask them. And then the moderator can interrupt in slides and ask me some of those questions to answer for you. And in terms of some of the clinical things, I kept in mind a little more of like a primary care type screening brief intervention, but I see some of you are social workers So if you have questions about other types of clinical approaches, please feel free to ask. I'm happy to kind of go off the slides and talk about other topics as well that would be helpful to the group. So with that said, I'm just going to start sharing the slides and jump in. All right, here we go. Okay, and I'm just going to do the display mode here. And everyone, all right, can everyone see that in the big mode? Okay,
We
awesome.
can see your presenter view.
Oh, okay. That's what I was trying to avoid. Hold on one second. I'm going to share I have two screens, so I will do this one. This should work. All right, trying again.
Looks great.
Okay.
Oh, actually, we can see the slides on the side. Sorry. There you go.
There we go.
Perfect.
All right, we did it. Okay. So I think you guys know the topic. So just learning objectives today. I'll present about alcohol use disorder, the definition and diagnostic criteria. I'd like to share more about population prevalence and trends, as well as highlight some at-risk demographic groups and health risks, and share best practices for screening and brief interventions in clinical or community settings. So in terms of alcohol use disorder definition and diagnosis, alcohol use disorder, many of you may be aware of this term, but it's a medical condition characterized by impaired ability to stop or control alcohol use, and in conjunction with adverse consequences in a person's life, and often some level of physical symptoms as well, craving, tolerance, and withdrawal. And alcohol use disorder, the term many people know, but I talk to people a lot who think that that's a strange term because they're used to other terms like alcohol abuse or dependence, which alcohol use disorder encompasses what those encompass as well. Many people in a colloquial sense or more historical, even diagnostic sense, use the term alcoholism, which the field has moved away from in part to recognize the spectrum of alcohol use disorder, and the term alcoholic for many people can be very stigmatizing. I find for some it can be empowering. It kind of depends on the person. So typically clinically and in talks, I use the term alcohol use disorder. And when we talk about what an alcohol use disorder is, this is a diagnostic term. It is the diagnosis, and it is made of 11 symptoms. And those 11 symptoms are highlighted here. You have to have at least 2 of them to meet criteria for an alcohol use disorder. And that includes those physical symptoms I mentioned, like withdrawal or tolerance that are happening in a person's body, and other things that often are more observable on the outside subjectively, a person increasing how much they drink or the frequency or length of time, their inability to control their use, or a desire to stop, lots of time using, obtaining, or recovering from alcohol while giving up other activities in favor of spending more time using alcohol or using alcohol during those activities. One of the ways I describe this in clinic to people sometimes is sort of like a planet, like does a person's life or does an individual's life start to revolve more and more around the substance? Like that substance has more gravitational pull. They're not doing as much as they used to. They're spending more time focusing on alcohol use. So off this, another criteria is giving up their use, or sorry, continued use of alcohol despite medical or psychological conditions that are negatively impacted by alcohol, recurrent difficulties in fulfilling other obligations and roles in their life, recurrent use in hazardous situations. So this could be driving, this could be risky sexual situations, but hazardous situations, you know, like where bars may be getting into fights, craving or just strong desire to consume alcohol, and continued use despite personal challenges, sometimes with relationships and work and other things. So if someone meets 2 of those, they would get a mild use disorder. 4 to 5 of those symptoms are considered moderate, and 6 or more are considered severe. And this was a big shift in how we conceptualize alcohol and other drug addictions, that's taken place over time to see it as a spectrum rather than a binary. So originally it was you're alcoholic or you're not alcoholic. And then it was alcohol abuse versus dependence. And now it's more and more being seen and scientifically being validated as a construct that has a continuous presentation in individuals, where someone can have a more mild problem or a very severe problem, which I'm sure you have seen anecdotally in your lives as well as clinically. And when we talk about diagnosis, diagnosis is a more formal process. Often this is going to be done by a specialist, a social worker, a psychologist, a psychiatrist, sometimes a doctor. But there are also other ways to detect hazardous alcohol use that may or may not, that may indicate potentially having an alcohol use disorder, which I'll talk about just in a little bit later. So in terms of epidemiology of alcohol use, so there's a big survey that takes place every decade in the United States. The most recent one just took place, so I'm eagerly awaiting the data publications that come out of it. But when we've looked at this every decade survey over the past series of years, you can see from this line a pretty obvious trend in which alcohol use is increasing in the population, and also the rate of that increase is starting to go up. So this is anticipated to continue over this most current decade based on data that's available. And so 1 in every 8 Americans has an alcohol use disorder, and this is probably actually much higher at this point, which is fairly alarming when we think of the incidence of other chronic conditions in the United States. And concerningly, the trends where it's gone from about 9% of people, or 8.5% of people with an alcohol use disorder, to 12.7 is a percent change of 49.4%. So a 50% increase over that decade, which we, again, all data points to that trend continuing to go up. Oops, sorry, my clicker's not working. So as we see this trend in alcohol use disorders increasing, we also see alcohol use disorder related mortality increasing in the US. So this map of the United States, anything that's pink in color or a deep purple is increasing mortality. And the percent change in some areas, as you can see with this kind of deep purple, is sometimes up to doubling or tripling over time. And in Michigan, you can see that in some areas. Most areas have increased. I'm actually happen to be in New England right now. I'm from Rhode Island. Is a very, troubling trends in some of those areas, that mortality from alcohol use, thereby also the upstream alcohol use disorders, are increasing pretty quickly in some of these areas of the country. And so as practitioners, we think a lot, I think, about chronic health effects, social effects, ill effects of alcohol use, and don't always maybe fully wrap our heads around how much impact this has just on mortality and morbidity from a health perspective. And this data is really striking in that sense. Another contrast that I often like to point out when I'm talking about alcohol and alcohol use disorders is comparing it with opioids. So there's this huge national conversation constantly going on over the last 10 years about opioids overdose, fentanyl, and all very tragic, terrible addiction and overdose statistics. However, we often don't talk about the same trends that are happening in alcohol use and are actually much more severe. So if you look at this slide moving from the bottom up towards the top, alcohol kills 140,000 plus people every year, while opioid overdose or overdose deaths in general are 80,000. And emergency department visits are much, much higher for alcohol-related events than for opioid-related events. And the number of people with an alcohol use disorder relative to an opioid use disorder is strikingly higher. And the percent of the population that uses alcohol is enormous, up to 80% plus of the population while a relatively small fraction uses opioids, at least in a misuse. So I like to anchor the conversation in this just because a lot of times alcohol is very normalized. It's something that a lot of people do without great incident or adverse effect. But in reality, when we then look at the population level, it's a little bit of an illusion that it can be, that it's not as big of a public health crisis as opioids or other drugs, when in fact it's actually a bigger problem and is following the same upward trends in our society. So with that in mind, kind of thinking about what are the at-risk groups, or are there certain subsections of the population that are more affected by this than others? This was just a quick Google search that I did. I typed in the word alcoholic, even though that's not the word I'm normally using, just to kind of get that, population Google snapshot of the images that come up. And does anyone notice anything in particular about this very non-research based search that I did?
Primarily men.
Yeah. So primarily men. Anything else? So primarily men and primarily white Caucasian men. And I actually counted, from what I could tell or ascertain sex from the pictures, I counted 24 men, 4 women, and 1 frog. So that kind of gives you just a little bit of a snapshot of at least this little experiment that I did. And so comparing that to what the actual alcohol use rates in the country are like is interesting to do, because we do have stereotypes about who we think of as a person who would have an alcohol use disorder. And so this past year prevalence data was 6 different studies that were brought together to take averages on some trends in alcohol use, and finding that this first one is men versus women. So this top line is men and this solid line is women. And what you'll notice here is that men have higher use overall, but women are increasing. This is time on this bottom x-axis. So over many years, women are essentially catching up with men. And I have some other slides to demonstrate that in other ways. White Americans, people who identify as white Caucasian, also have the highest rate of use. But as you can see, some other groups are catching up, including Black, African American, and Hispanic individuals. So we have this phenomenon of kind of like high levels of use, but then the rate of use being really important as time has gone by. Similarly, with younger adults, the youngest adult group is the highest level of use, with other groups catching up again. And those with more than a high school education also have very high rates of use. And when we look at this for men versus women, you can see that the bar graphs, the yellow is the more recent data, and how much more of an increase there's been in use in women relative to men. And this is for alcohol use disorders specifically. So our most severe category that we're going to be most concerned about in terms of morbidity and mortality. And so to take a little snapshot of that, the percent change in men over that decade was 34%, but was 83.7% addition for women. So a much higher rate of increase. And this also illustrates it pretty nicely when we are looking at hazardous use, so unhealthy levels of alcohol use in women versus men across Western nations. We can see women just going up very quickly to kind of meet men at this high level of alcohol use. And we can see some of these trends in terms of the mortality data as well. So deaths from alcohol have also increased pretty rapidly in the United States recently, especially over the last 10 years. And there's many causes of death from alcohol use. I think a lot of times we think of alcohol poisoning, or we think of car crashes. The largest category that leads to death is liver disease. from alcohol, which alcohol is now the leading cause of liver disease in the United States and the leading cause of death among people who use alcohol. So there's even a very particular and specific risk group. So for clinicians seeing people with alcohol use disorder, being aware of signs, symptoms of liver disease, and being aware of this high incidence that's happening in the country and the increasing incidence of that is really important. And there was a big effect of the pandemic on alcohol use. I think a lot of people probably saw some of this in the news. And likewise, there was a bump in alcohol-related mortality. So there are some pretty striking data that was looking at alcohol-related liver disease in Americans during that, when the pandemic began, right here close to this 2020 mark, how much they shot up and then started to come down a little with the pandemic restrictions loosening. And California was one of the states that was hit really hard by this trend. And at this peak, deaths from alcohol-related liver disease were outnumbering deaths from car accidents. And I think also from certain forms of cancer. It was just a really, really striking increase. So to kind of ground it in some other comparisons, that this is a cause of death that's really that's just really increasing, comparable to things that we think of often, where I think liver disease from alcohol is something is not as much on people's radars. And similarly with those trends that I mentioned in terms of increase in alcohol use disorder, in particular risk groups, those increases really took place similarly in women in terms of liver disease, and also in young women in particular. So when we're thinking of people who are going to have liver disease and die from liver disease, often we have a certain image in our mind, and it's usually not a 30-year-old woman, but in fact, that's one of the highest increasing groups that's experiencing this outcome. You can see here, this white bar here is women. This is percent change over time. And in this young group, it's particularly high for men and women, but it's consistently high for women overall across most age groups under 65. So
Dr. Fernandez,
yes.
sorry to interrupt. We do
Yeah.
have a question. Do you want me to read it now, or?
Yeah, that would be great.
Okay. How come the survey most current is 2013 to 2015 for AUD? Is there not a more current rate? I see there's one slide during the pandemic.
Yeah, so that was what I was mentioning about this. There's something called the NESARC. It's National Epidemiological Survey of Alcohol Use Disorders, which is one of our best data sources. And it takes place every decade. And they just finished it for this decade. So some of that data I'm showing is our most recent data from that survey, which I think I check online to see if anything's been published from the new version every once in a while recently, because I'm just waiting for it. But there is NISDA. There's some other data sets that have other updates. Just that one particular survey that is a really good marker of alcohol use disorders is a every decade survey, unfortunately. But there's definitely other data online, and in particular during the pandemic, I was trying to highlight some of those increases. But yeah, there is more recent data that shows an increase, just not consistently with that one data set, if that makes sense.
Thank you. There is another question. Would you like me to read that?
Yes.
Could you comment on the possible increase in FASD, ARND due to the increase in women's use of alcohol, please?
And so is this I think you were saying fetal alcohol syndrome was FAS, if I heard correctly.
FASD/ARND.
Oh, okay. Yeah, so I think fetal alcohol syndrome. So I actually don't have the data on that specifically. It's not something that I study and work on as well. So I'm fairly certain the trends, like the upstream factors, just like with liver disease or other health causes, The upstream factors are increase in alcohol use and increase in alcohol-related liver disease. Increase in alcohol use disorder. So when rates are changing in young women of childbearing age, I can only imagine that those are increasing as well. I don't have the data in this slides, though.
Thank you. And
Yeah.
then the last question is, would SAMHSA have some data too? The Substance Abuse of Mental Health Services Association.
On alcohol use disorder?
Sorry, on the first question around the survey data.
Oh yeah, so SAMHSA, I think probably there's a few different. NISDA is one, and SAMHSA has some as well. Yeah,
Thank you.
yeah. Okay, so in terms of the biological or anatomical differences, when I was mentioning some of those differences with women versus men and the increase in alcohol use in women, something important to keep in mind is that men and women have biological and anatomical differences that are important when we think about alcohol use, because it's not just a weight difference. You know, obviously there's a difference between women when I'm talking about women versus men, I'm talking about biological sex as opposed to gender. But women tend to have a lower body weight and size overall, but that's not the only reason that this happens. So water is a factor, how much water is in the body. So alcohol is diluted by water, and women have proportionally less in their bodies, 52 versus 61%, and older adults also have less. So there's also differences in alcohol dehydrogenase, which means slower processing of alcohol in stomach and the upper intestines in women relative to men, as well as fairly complex hormonal differences that impact the way that alcohol is processed in the body. So what this means for women is that they can become intoxicated at less use of alcohol, but also more of the damaging effects can reach their organs. So those harmful effects and health hazards of alcohol tend to happen faster in women than in men for these reasons. So this is sometimes called telescoping, in the sense that women start to have alcohol-related problems sooner and at lower drinking levels than men, and that there's an accelerated progression from initiation of alcohol use to addiction, treatment admission, and also things like liver disease. And women are just generally more susceptible in that sense to alcohol-related organ damage. So in terms of alcohol use disorder clinical practices, I want to sort of couch some of the discussion within the changing AUD trajectory and things that probably need to happen in order to curb this. And it's really a very broad set of interventions or policy changes to make a major change in population level trends. We can't do all of it at an individual level as clinicians, of course. And so things at level of policy are really impactful on trends in the society. So likely interventions need to happen at that level. Public health efforts at an organizational setting like integrated care, interpersonal in families and communities, as well as the individual level, which is a little more about what I'll talk about today, given our focus of this session and the clinicians that are here who are meeting with people one-on-one. And most interventions and published research are focused on interventions and research that do assess at the individual level, including things like attitudes, belief, and demographics. So the question is really, what can we do at an individual level? And as I mentioned, I focused a bit more in some of the slides that I prepared on things that can be done in a more general clinic setting. So if there are questions about other specific treatments, please chime in. But generally, one of the most well-known practices that can be done across multiple types of healthcare settings, community and counseling settings, is to do screening identifying alcohol use or alcohol use disorders, brief interventions for harmful drinking and alcohol use disorder, and then referring for those people who have the more severe manifestations of alcohol problems, which are the more moderate to severe alcohol use disorder. And importantly, there are tools for screening. So many healthcare settings do not use validated screening tools. They'll use more informal questions like, how much do you drink? How much do you drink a week? Where every single research study that compares that approach to a validated screening tool, even a 3-question screening tool, finds that the screening tools tend to do a better job of identifying and capturing risky alcohol use or potential alcohol use disorder. And there are quite a few of these tools that have been validated. One of them that's very brief, I highlight because it's only 3 questions, is called the Audit C. And it asks about how often someone drinks alcohol, how many standard drinks they have on a typical day, and how often. The wording kind of differs depending on the standard drinks in the country that it's being administered in, but how often do you have? Usually it's 5 or more, or 4 or more for a female, or 5 or more for a male. And then this leads to, as you can see, there's a numerical, there's numbers across the top that correspond to scores, and you can come up with a standardized score. And the reason that that's important is because the score can lead to certain clinical decision rules about what to do next with someone who scores positively and has above certain cutoffs. So, for example, for men and women on this measure scoring a 0 to 4, and different clinics use different cutoffs. Sometimes women at 0 to 3, which is preferred actually, but for men it's usually 5 or more. And so and for people who are under 65, the cutoffs are even lower. So depending on what someone's score is on this measure, you can use that to make a decision if you want to talk to a person and give them feedback about their level of alcohol use. So if they score above the cutoff for hazardous use, you can talk to them about cutting back on their use, about harm and potential benefits of making a change. While if people score even higher, like above an 11, there's potentially a more severe alcohol use disorder going on. There are other measures as well, such as the audit, which is a 10-item measure. Not all clinical practices have room to assess all the chronic health conditions that they need to with a 10-item measure. So the audit C is usually at least a minimum to get started for clinics. And it's one that's been used in a lot of different types of health clinics in a lot of different settings. So it's very widely validated in that sense. And when there's been research that compares the Audit C with a general open-ended clinical interview, this particular study was with hepatology, they found that someone just doing their best at clinical questions captured a much lower number of individuals with potential alcohol problems than a tool, or compared to someone who is an addiction specialist doing a special interview. So these tools can really help in practice, especially when a practitioner is busy and needing to do other things, to take some of that clinical interviewing out and get those cutoff scores. So another really helpful tool for estimating or detecting alcohol use in an individual is alcohol biomarkers. So some clinics can do this more easily than others. The 2 that we use most commonly in the clinics I've worked in include ethyl glucuronide for short, which is a urine test. Many addiction clinics already do urine screening, and it can detect alcohol use for the last 3 to 5 days with fairly high sensitivity and specificity. The other really strong alcohol biomarker that less people are aware of is called phosphatidylethanol, or PEth for short. And this is actually a blood biomarker. So in some settings, when determining someone's alcohol use is really imperative for various reasons, this test can be really helpful. It has very, very high sensitivity and a low rate of false positives, and the thing that's been really a breakthrough in terms of testing is that it can detect 2 to 3 weeks of use as opposed to a few days, and sometimes up to a month. And quantitatively, it is meaningful. So while ethyl group, the numeric value that you get back, doesn't give you a sense of how much someone has been drinking, the PET value can indicate more heavy chronic use versus lighter use. So it's a really useful test for clinics that have the resources and want to implement it, and is something that both in research and clinical practice I found has been really helpful in terms of detecting alcohol use, and initiating discussions with people about that use when needed. So those are ways to detect and screen for alcohol. And I'll talk a bit more now about what to do when positive scores come back, or the next step is to talk to the person about their alcohol use and counsel them about alcohol use reduction. So the term that's widely used for this practice is SBIRT, screening, brief intervention, and referral to treatment. It's a service like blood pressure or cholesterol screening. It's billable through insurance. And the main steps are using, like I had mentioned, a validated set of screening questions and using those cutoff scores to drive a short conversation with patients who are drinking above recommended amounts, and then making referral to treatment when appropriate. So there are so many publications and manuals that go into these practices more briefly than I can get into here. But for those who are interested, I have a few up here. They're published by SAMHSA, World Health Organization, and a lot of other organizations. If people are interested, you can Google that and find many, many helpful articles. So it's much beyond the scope to go into all the brief intervention practices, but I'm going to try to hit on what the main effective components are that people can incorporate into conversations with people about alcohol, and mention a few of the pitfalls that often people fall into when they're talking to patients about alcohol use. So one of the first ones, so I mentioned screening, and I'm sure you've all had this experience. You go to a doctor's office or clinic, you fill out information. Sometimes it feels like you fill out the same information 5 different times. It seems to go in a file, and it's unclear if the doctor ever sees it. So that's a big barrier to screening being effective. So patients do, when they do studies of this, patients do often feel like their doctors or clinicians don't actually review health information, and then it doesn't always get discussed with them. Impacts, the patient's trust or feeling like that information is being used. So doing alcohol screening, actually using that information is really important, not to just do it to do it, but to use it clinically. So this is just another example. This is using the audit, which is what I mentioned is the 10-item version of the audit C. Or the DAST, which is a drug use measure. This is just showing how you can use these scores to drive the conversation using really clear cutoffs, where lower scores require just some brief information or about alcohol use, while if someone is in a risky tier, you would do a more focused conversation called a brief intervention. And when it's a more harmful level, you would also refer that person to treatment.
Dr. Fernandez?
Yeah.
There's a question. Did you want me to save it or?
Sure, yeah, jump in.
Okay. I have had patients get very angry with PETH screening for LFT elevation. They swear it is wrong. Is there anything that can cause a false positive?
So it's very rare. So one of the things that can happen is blood transfusion. So in rare events, if someone's had a blood transfusion, it can be that there could be alcohol in the blood of the transfusion. So that's one time it's happened in studies. When the scores are very low, it is possible that it could be a very small amount of drinking from a more distal past. So that can happen. And I've had the same situation many, many times where a patient will just swear up, down, right, and left that a test is inaccurate. And when the scores are very low, I sometimes am a little more, can believe that that could be true a little more. When they're very high, it's very unusual that that would happen. However, the caveat that I would say is there's no perfect biomarker and there's no perfect test. And so whenever I think about testing, it's a data point, and you have to incorporate your data point with the other information you're getting from a person. And the way you present the information can also really change the conversation. Although sometimes it doesn't matter how you say it, the person will say no. I think sometimes that can be accurate, and sometimes it can be that a person doesn't want to share that information. So in those cases, trying to have a conversation with the person, talking to the person, this is one data point. We always talk to our patients about this. We don't just take this at face value. I want to hear what's going on with you. I'm here to help you. And trying to couch it into a positive, that this is an opportunity for a healthcare provider to be aware of what's going on. Trying to think about like how can you frame the conversation so that disclosing is of benefit to the participant, and many people just, they don't want to feel judged, or sometimes in the case of liver disease, there can be some major consequences for use. So it's not a simple thing. There's actually a publication, I think it's in press right now, that should be coming out soon, that Scott Winder, who's a psychiatrist here at University of Michigan, wrote, and I helped to co-author. He was the major driver of this paper, but it's called What to Do with Discordant PEth. So the whole paper is about clinically, how do you manage discordant PEth in a compassionate conversation? What are next steps and other things you can do? So I think that should be published relatively soon, because I think it's a really important clinical area, especially when there's some high stakes issues attached to those test results, which there can be in cases of courts or liver transplant or other things. That's a really good question. Yeah, so jumping back in, so for brief interventions, one of the ways that I encapsulate this is this idea of just advising and assisting. And this is some of the things, without going into all the details of what could be in a brief intervention, which are more in those manuals, but there's a few really basic things to do. One of them is to state your conclusion and recommendations very clearly. Based on your audit score, you're in this risk category. We recommend that you reduce alcohol use or stop in this way. And then try to gauge motivation and tailor discussion accordingly to where the person is at. And what you've probably heard is that stage of change. Are they motivated? Are they not there yet? And try to adjust your conversation accordingly. And if appropriate, providing education. Some people are willing and want to do something, so making a plan and providing referrals as necessary. There's a communication style called motivational interviewing that can be really helpful if you have training or are interested in training, that can help. It's to help guide these conversations and use that skill set to help guide people towards change, even if they may initially feel defensive about that. And I wanted to really highlight this phenomenon that happens with alcohol use relative to some other chronic health conditions. So you can imagine if someone has diabetes or prediabetes, there's a very straightforward conversation. Here's your diagnosis, here's the risk, here's what we think you should do. And the same thing happens a bit for smoking. So this was a qualitative study that looked at recorded conversations between doctors and patients about smoking. And the finding was that the smoking related conversations were very direct and straightforward, and the alcohol conversations were very vague, unfocused, and uncomfortable on the provider side. So this example is a provider saying, you should quit too, to the wife of this patient. Bring your whole household in. I'd like to see you have a little bit more of a plan in place. So very direct, very specific. While in alcohol, the examples were things more like, you're going to need to be careful about that. You should be careful not to get yourself into trouble. So there's really a big difference in how clinicians sometimes initiate these conversations. For whatever reason, we could hypothesize, I'm sure, about why, but that really needs to change. And it's something that's really good to be aware of as a clinician, as you monitor your own behavior, is what is your language? Are you speaking directly and in a straightforward way, but also a compassionate way, working with someone's motivation, just like you would with smoking, but also being really clear about what you see and what you recommend is really important, even in a brief intervention. So the other pitfall that a lot of clinicians or clinics can run into is there also needs to be follow-up and support. So these really aren't one-time conversations and assessments. And just like any chronic health condition, you wouldn't expect smoking or diabetes to be a one and done conversation. This would be an ongoing follow-up, support, and plan that acknowledges the waxing and waning nature of an alcohol use disorder or of drinking behavior in general. And I think that is something, just like those conversations that often are a little bit squishier for alcohol. Likewise, some of the follow-up and planning and support, like, hey, I want to see you back in 6 months and see how this went in like a primary care setting, or in a more social work, psychology, psychiatry practice, maybe, next month when you come in, I'd like to follow up with you about this. So really plan to and make that statement to the patient, following up at the next visit, checking in about change, supporting any positive change, and reassessing and diagnosing risk criteria at intervals. It changes. People can relapse, people return to drinking, people return to high levels of drinking even after low risk. And then again, making referrals as needed to addiction specialists if that's needed. The vast majority of people with alcohol use disorders or risky drinking, maybe you've seen that pyramid, where the base of a pyramid is people with more mild to just hazardous use or mild alcohol use disorder. So the majority of patients actually do fall into those categories. And as you move up into severity, moderate and more severe alcohol use disorders, the numbers get smaller, but the needs are greater. So those are the patients that really need those referrals, but the majority of them can often be managed in less intensive settings. And to end on a very, well, in some ways discouraging, but also encouraging note, is that the number of patients that actually get into alcohol use disorder treatment. So this is a study that was done with liver disease patients, but the numbers are almost exactly the same as with alcohol use disorder as patients in general, which is that people with alcohol use disorders, only about 10% of them go to specialty treatment that get any kind of treatment or relapse prevention medications. So that's staggeringly low. But the opportunity that I see is everyone in orange on this slide. So everyone in orange on this slide is someone who's not getting anything, which means there's a huge number of people that even having the most minimal conversation with them about alcohol use is more than they would have gotten. And if you even get a few of those people, you're suddenly having a huge impact because the numbers that exist that are getting those are so low. And so if we can see this as an unreached population, it's an untapped population that needs help and guidance. And a lot of times they are the people with the more mild to moderate alcohol use problems, that their problems aren't severe enough to get them either mandated to treatment or to seek it on their own. So if we start to kind of lower our bar about like, who are we going to talk with about alcohol, engage those people in discussions, refer them to treatment, any success we have is moving the needle. even if we get 1 out of 10 people that we talk to get to some kind of treatment, we've made a huge impact. So that's one of the things that I just want to make sure I highlight is in our line of work, when you're working with addiction patients, chronic health conditions, where motivation is a really big factor and access to care can be really challenging, it's very easy to get discouraged and feel like you can't have an impact. But you really can, in the sense of getting that 90% of people who really aren't getting anything. You get somebody in and you've moved that needle in a really big way. So with that, I just want to take questions and thank you for listening.
Thank you so much, Dr. Fernandez, for this presentation and for the valuable information. For anybody who has questions, if you want to go ahead and post them in the Q&A section, I can read them out loud. There were a couple questions, Dr. Fernandez, that came in with registrations. The first one is, what are some new and promising interventions for the treatment of alcohol use disorder?
Yeah, that's a great question. So I think addiction treatment is not a very fast moving field in terms of treatments and new treatments. So the evidence base, there are some. I guess I'll start with kind of what's standard of care and what continues to be standard of care, and then talk about some of the more recent research. But some of those things I presented, the screening, brief intervention, referral to treatment, is still a very strong standard of care that's effective across settings. Cognitive behavioral therapy as a therapeutic modality is really well supported by evidence. And one of the other areas that's really important is both psychotherapy, like CBT, cognitive behavioral therapy, plus relapse prevention medications, like naltrexone is one that is effective for many people who have alcohol use disorder. And a very low number of people actually get those things together at the same time, but the combination of them can really improve above and beyond any one of them alone. So honestly, when I think of what's a hot topic, it's that we have treatments that work, and they work as well as treatments in other fields. Like we think of, oh, not everybody gets helped by alcohol use disorder treatment, but like something like aspirin that was recommended for heart attack risk reduction was a much smaller effect size. It's just that on a population level, it can be really effective. So, if 30% of people benefit from CBT, getting that to people is still a huge and important thing to do. So when I think of like what's the most important is, can we get more people access? The biggest problem that we have in our country is people aren't getting care. So hot topic to me is get more people the treatments that we have. The other area that I do think is emerging as an important treatment that has not been put into practice in many clinical settings, in large part due to insurance barriers, is contingency management. So the most evidence-supported treatment for alcohol and other substances is actually something called contingency management, which uses incentives to reward desired behavior. So alcohol abstinence is actually rewarded by sometimes money. Like someone blows in a breathalyzer, has negative screens, they get small amounts of money to reinforce that behavior. Or you get incentivized to go into your clinic treatments. So you go to clinic, you can pull a raffle, you get a small prize. So there's all these really interesting kind of positive reinforcement incentive-based treatments that are incredible when you look at them in research, but they've had a lot of barriers to actually being implemented because there's a lot of stigma, there's a lot of issues, of course, around paying people for abstinence that aren't the first and foremost idea for people's insurance payers. So, but I think when I think of, okay, here's something that a lot of people aren't using and don't know about, that's one of the things that comes to mind.
Thank you. There is a comment in the chat from Lisa saying Cochrane database shows 12-step programs to be the most effective intervention in treating alcohol use disorder. Can you please comment?
Yeah, so 12-step. So I should mention 12-step, generally speaking. I don't know if in that sense 12-step as like a therapy modality or 12-step as a peer support modality. But 12-step is an incredible program and approach. One of the things that I appreciate about it as well is that it's free, it's everywhere, and anyone can access it. And so basically the idea is that like this is the most ubiquitous treatment that people can access without insurance. So I don't know that particular study, although I can't comment on the design and the methods. One of the tricky things about 12-step is that it doesn't always partner with research. It's obviously an independent body. So but I mean, it's a wonderful program. 12-step facilitation therapy, when they've studied it more formally in treatment settings, is just as good as CBT. And so it's an amazing program. It's one of the empirical supported treatments that we have, research supported treatments that we have. There's also other free services that some people benefit from that aren't as well known as 12-step, like Smart Recovery. There's a Dharma, Buddhist kind of focus. So there are a suite of things. And so it's great to have those, especially free services for people.
Agreed. There is a question. What was the source you mentioned earlier that collects the data every decade?
Oh, NESARC, National Epidemiological Survey of Alcohol-Related Conditions, I think is what it stands for.
I'm trying to put this in the chat.
Yeah.
National Epidemiological Survey of
Alcohol-Related Conditions.
Okay. Thank you.
Yeah, NESARC.
Okay.
Yeah, so the new decade, like this decade where they're collecting the new data just happened. So I think publications on this next 10 years with that next line in that graph should be available soon.
Great. Thank you so much. We really appreciate you being here and sharing this information. We will send out the slides to all attendees. And our next event is on November the 14th from 12 to 1, Novel Psychoactive Substances of 2023. I can put the link in the chat for those of you that would like to register, but we also are going to be sending this out as well. So thank you so much again, Anne, and thank you everybody for attending today. We hope you have a good Thursday.
Thanks, everybody.
Thank you.